Hi, listeners. I'm Lawrence Yang, family doctor in Surrey. Let's start with a round of introductions. Um, Quynh, please introduce yourself.
Hi, I'm Quynh Doan. I'm a pediatric emergency physician. I'm also a health services researcher, and I'm the director of clinical research at the BC Children's Research Institute.
Yes, and this is your second time on the FTS podcast. Thank you for coming again. Kathleen, please introduce yourself.
For sure. I'm a family doctor. I work in Coquitlam in New Westminster. I work in community setting. I work in the high volume obstetrics clinic, and I harvest graft material in the open heart surgery program. Very exciting. I've been involved in medical leadership at lots of different levels, and I'm the current president-elect nominee for the Canadian Medical Association.
Yes, yeah, it's always exciting to hear about your different projects to shift and change our system. And a few months back, you had contacted me, Kathleen, about trying to get some type of metrics for the violence that health professionals experience within the course of their work as health professionals. And then coincidentally, a few months later, Rob Hewlett from Doctors of BC said, there's this person, her name is Quynh Doan, and she's a go-getter. She's someone who's really interested in research and also making waves in our system. And it turns out that you're working on some type of project with the section of emergency medicine around this. Tell us a little bit about that violence prevention metrics project you have.
Yeah, so this actually came out organically from our last AGM and conference. We had a panel of specialists talking about violence in emergency. And one of the topics that came out was, how do we advocate? How do we move the needle forward? We need data. We know everybody's experienced it. Anecdotally, everybody can say that they've experienced it, but we also know that we don't experience it to the same level, depending on who you are, how big you are, your color, your gender. You don't experience the same kind of violence or the same frequency. And so we have no numbers for that. The literature talks about many percentage of people have experienced it, but that doesn't speak to the frequency or the type or the targeted characteristics. And so we thought, well, we have an organization, we have a will, we also have the means to gather this data. So we started talking about building a registry, and little did we know Doctors of BC is also engaged with a working group to look at the work environment. And so that's when we got to collaborating and talking about this.
I've actually never heard of a clinical section under Doctors of BC, such as the emergency medicine section, going and putting resources together and a team together to actually do research about something. Is that something that's happened before?
That's funny. So I bring the research flavor to it because I don't do anything that I don't try to find a research angle to it. But the section is not necessarily doing this for research. They want to collect the data to advocate, but also to evaluate any intervention that we may implement. And so that we are not just throwing time and effort and money into interventions that are not going to be impactful. And I only know one way to do this rigorously, and it's through research. So I kind of, influence a little bit.
Our last podcast, you spoke quite a bit about kind of designing infrastructure to make research more efficient and effective and make it easier for us to do research in the clinical spaces. And I think we miss so many opportunities to capture data that can be used for improving systems. Mm-hmm. And I think that's the conversation that you had with me. You were saying we need this data so that we can advocate. What did you mean by that when you were speaking to me a couple months ago?
One of the challenges, and when I spoke to you, I was still president of the Royal Columbian Hospital Medical Staff Association, and that was really what we were trying to find out. We had many of my colleagues, department heads, down to the grassroots, even one regional head, really highlighted that not enough people report when they've been threatened, when they've been followed to their car, when they've been physically assaulted. If there's not a significant injury, the reporting mechanism doesn't exist. Yeah. And there was a thought and a theory around why we didn't report. Sometimes it was that we were too busy. Sometimes you didn't want to start a WCB claim. Sometimes you were afraid that, your colleagues might think that you put yourself in that situation, that, you should have read it better. And there's a bit of a timidness. So we brainstormed a little bit at our site and thought it would be appropriate to try and build an anonymous reporting system so that we could better track how often is this happening and who's actually inflicting violence or psychologically unsafe environment on our members, because it's not always the patients.
So did you at Royal Columbian actually go ahead and create a metrics program or some type of data
We
collection?
have not started that project yet.
Oh, okay.
There's multiple other things underway, and unfortunately, it's just a matter of time. But
Yeah,
that's what part of the reason I was speaking to you is working
Yeah.
on the provincial working group
yeah,
for physical and psychological safety, was to see if there was a bit of buy-in. We did talk to the health authority around that, as they have a robust reporting system for staff, but physicians are not included in that reporting system.
yeah. So like nurses, respiratory therapists, any other employees of the health authority do have a reporting system, but as physicians, most of us don't even know who to report to if something happened to us.
Exactly.
And I
So-
think historically, we just suppress it and just move forward. We just pretend like it didn't happen and try to just do another day.
But I think the issue with reporting in the health authority is twofold. First, if you report to the health authority, they're bound to respond to it and do something. And so there may or may not be an incentive to reach out and collect everything.
Oh,
The second aspect is, as physicians, time is a rare commodity. And
yeah.
so if you report into a system, you want to know that it's going to lead to something, or you want to know that that information is going to be accessible so that you can advocate. And the concern is, I mean, we have the PSLS system, right? Which are incidents that
The
we,
patient safety
patient
learning
safety,
system.
yeah. And first of all, it's cumbersome to report into it. Secondly, we don't know where it goes to and what happens to that information. Most of the time, we never hear back as to what happened to that PSLS. And so I think that the idea to report into a registry is what we're talking about creating, and to be able to see the dashboard with updated summaries and
Yeah.
data so that you know where the information is going to and what it actually is, what it represents. Are you alone? How often does that happen? Where? And the ability then to access it for specific reporting or academic writing or evaluating an intervention
Yeah.
is something that would be attractive to our members.
So, Kathleen was talking about anonymized reporting. We don't know who was attacked. We don't know who attacked them or was violent, like verbally assaulted or whatever. In the system that you're designing, are identifiers there at all?
Yeah. So I think when we think about the safety and privacy of data, we revert to anonymous as the safest. But you can make the data safe and useful without it being anonymous, so long as you have guards in place to protect the privacy. And I think that that's a balance, because if you make it anonymous, it's hard to identify characteristics and risk factors. It's hard to identify measures that work for whatever target population, right? So you have to know who it happens to. If you don't know that, then you're not very further advanced.
You're kind of
Right.
missing the opportunities for learning and the
Yeah.
specific context
Yeah.
that each report comes from. You can't really learn from that
Exactly.
specific context.
No, that makes sense. I think from our perspective, we were trying to establish some backbone baseline of what's actually going on and begin to shift the culture that we need to be speaking up about this. Because and I've heard that from many of my colleagues, that we don't speak up enough about it.
Exactly.
So that was less intimidating in the discussions that we had. We designed a survey that's actually ongoing right now around unconscious bias and anti-racism behaviors. And we included just enough demographics so that we would have enough information to move forward. And maybe that's going to be sufficient. Maybe we're going to have to drill down further, but a big item here has to be culture change.
Yeah.
And I kudos to your department. That's really incredible.
So I think that if we can the idea is to collect the demographics in stage 1.
Mhm.
And then you're in the registry, and every time you go back in to report an incident, you don't repeat your demographic, but it's linked. And we can stratify our analyses based on, okay, who does it happen to,
Yes.
at which site, that sort of things. But the other thing is, if you want to be able to use the data in a rigorous way, and you want to be able to state this is what's happening, the data has to be valid. And the problem with the completely anonymous is that you can't tell for sure that this is reporting honestly, or that it is reported by the population that you're looking after. If anybody can enter anything at any point in time, then I'm not suggesting that people would make this up, but it does add a layer of difficulty to convey to the public or to the stakeholder that this data is actually valid. If anybody can access it anonymously, then how do you know that this is real data?
Yeah, it's fair point. Yeah, fair point.
And so I think some of the anonymity programmed into some of the suggestions, that the thinking was to kind of reduce workload almost. The idea, the hope was that, and to simplify data gathering. But you're saying that we need the identifiers.
At least once, yeah. And then you have to put in place, separate the demographic from the incident in terms of where the data is stored, so that you protect the people who are reporting. But you have to have a way to link it back to ensure that, well, this is, valid data, people entering it. It's a real person, not a bot. That sort of thing happens.
So there are digital database security protocols that exist that can kind of take data from an original database that has identifiers, separate it out into kind of aggregate,
that's right,
anonymized data, which can maintain security standards.
That's right.
In fact, make it usable.
In fact, to build this, you have to go through a data safety evaluation. You have to get approval from the technology side of things, and from the privacy of information side of things as well. So it's quite a few hoops to jump through to set this up.
I actually had a nurse at the hospital where I work, and they said, I just have to turn off my emotions. I have to turn off kind of my feeling part, because I get so much abuse on a regular basis. And if I didn't turn off that part of me, I couldn't come to work. And that was heartbreaking to hear, right? It sounds like the emergency rooms are super overwhelmed right now, as primary care has reduced its capacity. Now the ER is really showing a lot of these signs. What is it about this topic that's driving you to make some moves in this area?
I think that this problem has always been around, right? But I think that the pandemic, the political movements, both in the US and in Canada, has changed the way the public perceives and interacts with healthcare provider. I think that some things happened in the last couple of years that's given people, freedom to mistreat each other in a much more open way. And I think that needs to be captured. Otherwise, you're shutting down the system that's saving you.
And I think the passing of Bill C3 is really gone a long way to raising awareness that this is a significant problem, and that it doesn't just apply to threats and violence towards physicians. It applies to those that actually work for us. In a community office, it is my front staff, my MOA and my nurse, that actually take the brunt of this abuse in a community office.
Yeah.
Not to say we don't see that in the hospital, we certainly do. But at the end of the day, we need to protect everybody.
I'm going to go and run and get the food. I'm so sorry. And I'll be right back. The delivery is here.
You want to pause it?
Yeah, I could pause it. You guys could. So, what were some of the things, Kathleen, that drove you to really want to work on this particular issue?
There were a number of intimidation episodes that happened to young physicians at our hospital that I heard about as president of the medical staff there. And it really wanted to push those people to actually report it. One of the most common was lack of safety in the parkade, because we were moved from the parkade immediately under the hospital to one that was a little bit farther away. And I have to admit that walking into that is a little like walking into a dark tunnel with no light at the end, like walking into a train tunnel
I
with no
remember
light at the
rotating
end.
there. It's scary.
And this is the new one. This is brand new. So to try and institute some safety measures that could prevent people feeling scared, especially when they've had a confrontation. And there's always that purpose. And the other note, just anecdotally, that we saw is that the number of code whites that we were hearing from the beginning of COVID moving forward. Code white is for security to come and attend at a specific site, and the number of code whites that you hear now far and away outstrips the number of code blues, where a resuscitation team, or code pinks for babies that the team needs to run for, and that has to say something. And something has changed in the culture in general at large. I agree, but certainly within the culture in healthcare, it's okay now to not be polite, to not be respectful to those that are caring for you, whether that's your nurse or your care aide or your pharmacist or your physician moving forward. It seems to be that's acceptable in the public. I gave that person that piece of my mind. And I think that there's a certain give and take. We have a position of power, and there's a power imbalance between caregivers and those receiving care. But there needs to be a level of understanding of where the boundaries are for physical and psychological intimidation.
And then having metrics might be able to provide us clues as to what is kind of causing these escalations in violence, verbal or physical. And then maybe we can take measures to redesign our system to reduce those risks, those risk factors for ourselves. Is that kind of what you see or foresee potentially for this project?
Yes, ideally. And the other thing is that there's also been, with this past 2 years, a change in culture and a little bit more freedom to be disrespectful. But the nice thing about this, the balance is that, with the pandemic, the last couple of years have also been eye-opening in terms of EDI principles. And so now that you know that, now you see that, you can't unsee that. And now you know about all of this. What are we going to do to implement these principles? What are we going to do to enact these principles and vision statements that every hospital has about EDI?
Okay, so you're saying that in our organizational culture in the hospital, now we've become more aware and are formalizing equity, diversity, and inclusion principles.
Yes.
We're trying to actually formalize them. Right now, they're just on paper, but we have not yet actualized them. And something like this might be able to capture data around inequity. Okay.
Well, like I will stand by it. I don't think that violence and aggression is experienced by all of us equally.
I agree with that. Yes.
Right.
Very true. Yeah.
And so the interventions have been one size fit all. We go to the same education session. The security system that we're going to implement applies to the whole place the same way, no matter who you are and when who's on when and when. And I don't think that it will be equally effective for all of us. And how do you demonstrate that if you don't measure the data?
How far along is this project so far? Is it still just in theory? And
there's a lot of moving parts. There are a few big things we have to confirm in terms of governance, because there's a lot of interest, which is great. But we have to iron out a few things about governance, funding, the technical part that I've been working in the background. We've got a protocol drafted up. We're working with a tech company that's affiliated with UBC to build this. We're going to start talking about the design soon in terms of the features and the various data point and variables and access. But we have to finalize who's going to host this and how do we put together the data governance structure. Everybody's going to want to be able to access this for different purposes, and we have to set up ahead of time, how do we access this, who reviews and approves access, and that sort of stuff.
And there's real value in keeping that data physician owned rather than disseminated ownership. I agree.
There might be some parties out there who say, don't do this project because we currently don't have the back end ready. We don't have the resources to actually respond to all these incidents. And if we just know that these incidents are happening and we can't actually do anything about it, it makes us look bad. What would you want to say to these stakeholders who might have that?
I would say that data collection, to the degree that it is valid and useful, takes time. Once you're ready for a solution, we will need a couple of years to collect that data. So I think we need to start, and then you can act on it when you're ready. But it's like, I will give you another example that's silly. Mental health. Suddenly we realize, oh, it's a problem, we have a crisis. Let's do this. Well, guess what? We don't know where the gaps are. We don't know how to target the population. All that data needs to be collected retrospectively. And I'm thinking we need to get that going.
Some of the listeners actually don't know much about the context within which you work clinically, but you work in a pediatric emergency room. A lot of people would imagine that working in a pediatric emergency room is just some cute little beings coming in who are tired and sick, and then you take care of them. But
there are a lot of very cute kids and babies, but they don't come alone. They're brought in by families, by parents, and those cute little babies also grew up to teenagers and young adults that we still care for until they're transitioned into the adult world. And again, with the stress of the pandemic, the human resource issues, we have surges. I mean, it's a lot harder to access care. People wait longer in our emergency department waiting room, and we all are slightly less resilient to stress. And so temper sometimes there. And then you have things like we talked about bias earlier, right?
Yeah.
You don't have to be outwardly, physically aggressive to cause harm. Your implicit bias, racism, sexism, ageism can be shown in so many ways in the emergency department that will wear us down, right? I'll give you a little example. East Indian physician goes in and reviews the case with their resident, who happens to be white male, and the family only addresses the resident or the student and ignores the attending, because in their mind, this is the main person. It doesn't matter that this is the guy who makes a decision and will take responsibility for their child. So little things like that, those little subtle things are not captured.
And Kathleen, in your workplace, you work largely in operating room a lot of times, aside from family practice.
And obstetrics is a big, big part of my practice. Yeah.
And in obstetrics, I'm sure that, emotions are heightened, and sometimes our natural, you can have some hairy situations there too.
Definitely. And what you're speaking about with regards to bias, we see a great deal, especially when we have ethnically based specialists, be they anesthesiologists or obstetrician gynecologists that are coming in consulting on a case. Sometimes even our residents will be completely marginalized. I've had patient ask for a different nurse, either a different gender or a different ethnicity, because they didn't want to be cared for by a particular person. And navigating those things are intimidating. And what you're talking about wearing you down is really about moral distress.
Exactly.
I mean, there are so many things ongoing, and a big part of moral distress is that there's such a large need in our patient population. And oftentimes we're not able to meet that need, be it a long lineup in the waiting room, a long lineup to get into my obstetrical clinic, a long lineup for your surgery, in and out of hospital multiple times. You're right, tempers flare, but we need to find a way to ensure that those people that are trying to make the need are able to do that in a way that's healthy for them as well.
Yeah, we are in a time of great shortage within our health professionals right now, both in the nursing area and physician area and all over. How much of this toxic exposure do you think is responsible for some of that resignation from actively participating in the workforce in healthcare? I know there's probably no data around it, but what's your gut instinct?
Yes.
Small, just yes.
I think it's possible. There's a lot of factors that go into folks retiring a little bit early. A lack of support for work personally or in your practice, a lack of resources for their patients. When I have patients waiting a year for a CT scan to follow up on a cancer diagnosis, that's tough to be the person on the front line saying, yes, we're still waiting. Yes, we're still waiting. And unfortunately, we do have people that die on our surgical wait lists, and trying to find a way to make it all work. I don't envy our health authority partners, the work that they have to do. But at the same token, as you mentioned earlier, we can't solve the problem for our partners, for other stakeholders, by not speaking the truth, by not actually identifying the challenge. I always harken back a little bit to quality improvement. What do we want to change? What's our goal here? Our goal is to try and improve the safe working environment for physicians and other healthcare providers. How are you going to know a change is an improvement? You can't do that without measuring basic start of the line data. And you can certainly chase it retrospectively, but it's less accurate and less meaningful.
Not in this case, right? So once you have, like, say a couple of years from now, you've developed an intervention you want to implement. Well, how are you going to demonstrate the impact if you haven't been collecting baseline data?
Yeah, you need a baseline.
Yeah,
data.
exactly. And I'm a terrible name dropper. I think it's Lewin's theory is that you have to, if you want to change something, you have to go and unfreeze something, unfreeze a process, change it, and then you need to refreeze it.
Yeah.
So we're right now in the process of unfreezing this, of exploring the challenge, naming the problems, trying to collect data around them. Once you have a bit more data, it's easier to implement those changes. Maybe we need additional security guards on when we know that there are more vulnerable providers that are going to be participating, right?
Even designing the intervention needs to be guided by data, right? You can't just say, okay, let's do this. Like, based on what? Why do you think this is what we should be doing? Who's that going to help? What's your maximum potential impact? If you don't know that, don't invest into it.
Oh, I wish that was true of so many processes
I know.
that get started without it. But I would say to those stakeholders that are arguing that don't bring this up because we can't fix it just now. We need to know what we need to fix.
Yes,
you need to make a proper driver diagram. You need to have a proper fishbone diagram of what's contributing into this. And then nothing's going to change immediately overnight. Things are going to happen in stages, and we need to probably design those stages together in order to be successful.
I want to thank you both for taking the time today speaking about this really important topic that impacts all health professionals and thereby the entire population of our province and our country. Now, if somebody has ideas or thoughts about this, this is optional. Do you want to share a social media presence where they might be able to reach out to you and ask you questions, or an email? Is that something you'd like at this time? Or I'm at Gateway Medic on Twitter. How about yourself?
I'm also on Twitter. I'm just trying to remember my handle. I think it's Dr. Kathleen Ross 1.
Okay.
On Twitter.
I'll post it once I find it.
I'm gonna have to admit, when I created the Twitter account, I wasn't so serious about it. So it's QD QWERTY. It's like the letters along the line of QWERTY, QWERTY on the keyboard.
Perfect.
Awesome. My initial QD QWERTY.
Yeah, absolutely.
Well, anything else you want to leave the listeners with today?
Please respect those that are caring for you. And if you see something, say something.
Absolutely.
Thanks, guys.